turn from the first to the last. I'm working on it. I can hear you. I can hear all of you, but
Yes.
my video is showing a problem now. I didn't
Okay.
understand. I'm trying to solve it. I'm trying to solve
so
it.
Dr. Tanju, we are here, and when you are ready, you can send the message, and everything will be okay.
Okay, I will. Okay.
Thank you.
Okay, bye.
So,
Tu peux commencer, c'est bon.
okay, it's okay. So, good evening in Algiers, good afternoon in New York, and good evening in Istanbul. Welcome to this webinar. I just have to precise that this webinar is a course that was scheduled before in our National Congress, which was supposed to be held on the 13th June. But unfortunately, with the problems of pandemic of COVID, we have to transform it in a webinar. And so it's a great honor for the Algerian Society to organize with the Education and Training Committee of WFNS this webinar about glioma, about advances in glioma. And without be late, I just give the floor to Professor Isabel Germano, who is the chairman. Of course, Professor Isabel Germani is professor in neurosurgery in oncology at the Mount Sinai Hospital of New York. She is the chairman of the Education and Training Committee of WFNS. She is doing a wonderful job in the field of education around the world. And she will introduce this course. And thank you, Isabel. Welcome.
Thank you very much. Thank you, Professor Suad Bakhti, for the pleasure and opportunity to share this afternoon, evening with you. As you know, we had tried to have an in-person meeting twice. The first time was canceled due to problems that were outside your control and my control, revolving around a visa that I did not understand that I needed, since I carry an Italian passport. But the second time, this is canceled because of COVID, which again is not something that we could have predicted. So I think that what we have learned from the pandemic is that we can all be together on a different way, and we have this wonderful technology. So I'm really grateful to be here today. I am very thankful to you and to the Algerian Neurosurgery Society for organizing this. I'm very thankful to Professor Suil Tliba and Professor Tanju Ukar, who are very active members of the WFNS Education and Training Committee. Their generosity for training and educating is really exemplar. My next slide here is just a brief message on what the World Federation of Neurosurgical Societies Education and Training Committee is all about. It is a committee that clearly resides within the WFNS. The WFNS is an organization that is non-political, and it is all the organized neurosurgical societies. We represent over 300,000 neurosurgeons, and the mission of the organization is that of really improving neurosurgical care throughout the world. And aligned to the mission of the WFNS, our committee's mission is that of working together with the parent organization to improve worldwide neurosurgical care, training, and research to benefit our patients. And our immediate goal is to facilitate neurosurgery education and training throughout the world, with particular attention to low and intermediate income countries by providing educational courses on site, online, web-based material and publications. Here is a slide showing that our effort is really a team effort. Here are the members of the committee, and every single one of the individuals is a phenomenal neurosurgeon, and is also somebody that believes that sharing experiences is important so that we can continue to grow as neurosurgeons and to increase our knowledge. So thank you to each of the members for their generosity. As you can see on the slide, we were able to actually get together virtually even before COVID. We used to use the platform called GoToMeeting. And so we, the WFNS Education Committee, was already familiar with getting together, not in person, but online. And I guess that this pandemic really exploited that. Here's an example of what we have been doing throughout the years. We like to partner with neuroscience societies. We like to partner with established educational activity. A great example is the IBNC in Turkey. That is a phenomenal educational activity. We like to empower new neurosurgical societies. We like to partner with annual meeting of LMIC neurosurgical societies, and we have been partnering also with continental societies. Needless to say, when there is a WFNS meeting, we participate with a special program, and we also like to develop new partnership. One of them was with MONS, and I know that some of you are members of that society. And also we like to look at new teaching opportunities. And when I say that, here we go. So this is the slide that I prepared in December to show all the completed on-site courses and the 12 that we were planning for the next 6 months. And as you can see, yours is one of them. But now the new teaching opportunity is that we do this as an online offering as opposed to on-site. So with that said, I'm really excited about this course today. I think we're all gonna learn from one another. This is a great program. And thank you again for participating. And thank you to the organizers for putting this together.
Thank you, Isabel.
Hi.
Yeah.
Hello.
Hi, Naja, how are you?
Fine, and you? So sorry, I just finished, so I just joined you. I'm in I'm driving.
So we will move to the presentation. Thank you, Isabel, for this welcome message. And without waiting, I have to introduce the first speaker of our webinar, who is Professor Fella Terkmani, who is one of our referents in neuropathology in Algeria. She is professor in pathology at the University of Medicine University of Algiers, and she is at the hospital at the University Hospital of Mustafa Pasha in Algiers. She has made her thesis about the gliomas. She was really the person who has to talk about the pathology and diagnosis, what has changed. I just want to say a few words about my friend Fella. She is a wonderful pathologist, because I didn't see a lot of pathologists like her, because she sometimes go to the operating room and she dress to see where is the tumor, to understand the location and to give us the maximum of information. So please, Fella, you have the talk.
Thank you very much, Suad. First, hello everybody, and all my thanks for all neuropathologists and all neurosurgeons, especially my friends Suad Bakhti and Nabila Tirilt, for this webinar. What we mean to know about glioma, and especially with this new classification, WHO 2016, and what has changed. I have a problem and I can't pass to the next. Yes, okay. If you look at this picture, we are sure it's the same. If we look behind the sample morphology, we will find the difference. So now we understand human pathology better since the advent of molecular pathology biology. The area of target therapy had changed the histological assessment, which went from purely morphological with the classification WHO 2007 with morphology and grading, and now we have the phenotypic via clinical data, radiological, and sure with immunohistochemistry and molecular biology techniques. With the WHO 2016 classification of tumor of nervous central system, and in particular glial tumor, has been restructured from previous edition to include a diagnosis schema that combine histological and molecular genetic information in order to provide the most accurate diagnosis and prognostic information. And so with what every neuropathologist needs to know, very interesting, with this NOS designation being used widely and disparately, which cause a confusion. So to address the CMPACT-NOW Working Committee clarified that NOS designation should be used when testing was not performed or didn't work. And if testing was performed and the test results were valid but didn't support the diagnosis of specific WHO entity, the recommendation was to use the designation of NEC. NEC, we mean with NEC, not elsewhere classified. For diffusely infiltrating glioma, we have the supratentorial. We can separate it into three basic groups. First, we have glioma with IDH and IDH and atherix mutation, strongly overlapping with much of an astrocytic phenotype. We have glioma with IDH mutation and 1p19 codulation, strongly overlapping with the histological pattern of oligodendroglioma, and glioma with IDH wild type, often encompassing typically glioblastoma. As a new entity, we have diffuse glioma of the midline with H3 key 27M mutation were also added to this group. David Louis proposed the incorporation of a layered diagnosis concept of brain tumor classification to combine histological and grading with molecular information. The concept was approved by the expert of the Harlem Consensus meeting and was then applied to the revisited fourth edition of the WH brain tumors classification. And we can use it for an example. If you have an oligodendroglioma with a morphology, a characteristic morphology of oligodendroglioma, you add a layer 3 with a grading. For example, in this case, we have a grad 3, so an anaplastic oligodendroglioma, and we add a layer 4 with a profile, molecular profile with IDH mutation and 1p19 codulation. And in the end, we obtain an integrated diagnostic, so anaplastic oligodendroglioma with IDH mutation and 1p codulation. And for oligodendroglioma is genetically defined with this new classification as diffusely infiltrating glioma with IDH mutation and 1p19 codulation. In the other hand, we note that the absence of alteration of atherix and TP53, the R132H IDH1 is the most frequent IDH mutation in oligodendroglioma, but it's now recruited to determine the IDH status by sequencing the gene in case the tumor doesn't express immunoreactivity. We have in other mutation like TRT mutation occur in high frequency in oligodendroglioma and ordinary glioblastoma, but not in diffusely infiltrating astrocytoma. But we note that WHO experts refuse the alternatively defined oligodendroglioma by the combined presence of EDH mutation and TERT mutation status. However, in the meantime, it was demonstrated that patients with diffuse glioma having an IDH mutation, 1P codylation status, have ended a similar prognostic than those with EDH mutation and TERT mutation status. Around 16% of oligodendroglioma carry CES mutation and may be associated to a poor prognostic. Perhaps in the future, very interesting. For oligoastrocytoma, the new classification recommend avoiding assuming the diagnostic of oligoastrocytoma size-sensitive tumors as now considered as either oligodendroma if you have EDH mutation or P19Q codylation, or astrocytoma if you have just EDH mutation. In fact, tumors with microscopic evidence of both an astrocytic and oligodendroglial component are still allowed to be diagnosed as astrocytoma NOS. For astrocytoma, the new classification genetically defined with the presence or absence of IDH mutation, similar to oligodendroglioma. IDH1 and 2 sequencing has to be performed if immunohistochemistry is negative. And we have 2 isoform coding for enzyme allowing the decarboxylation of the isocytrate. And we see an accumulation of alpha ketoglutarate. And if you have a mutation, you have this accumulation of 2-hydroxyglutarate. And we note a recurring mutation for the codon R132 EDH1 and R172 EDH2. Astrocytoma, we note genetically this classic diffusely infiltrating astrocytoma EDH mutation show in addition in nearly all cases a TP53 alteration, as well as in a large fraction we have an ATRX mutation. We have these 2 articles, very interesting article. The first one from David E. Rios and collaborator and all. He found the loss of ATRX expression was close to being mutually exclusive to 1P19 codylation, with only 2 of 167 ATRX negative tumors exhibiting 1P19 codylation. And the other article from Irakuzu Takami, we have a strong P53 immunoactivity in more than 10% of cells, provided the most accurate prediction of mutation, with a sensitivity and specificity began from 78.8% and 96.7%. For astrocytoma, you have in this new classification, the fibrillary and protoplasmic astrocytoma are combined, and the term or astrocytoma, diffuse astrocytoma, after many arguments indicated that these 2 subtypes are basically the same entity. And we have now just a variant, or only one variant, gemistocytic astrocytoma EDH mutation with EDH mutation. In this gemistocytic astrocytoma, we should constitute the gemistocyte should constitute more than approximately 20% of all tumor cells. The presence of occasionally gemistocyte in a diffuse astrocytoma doesn't justify the diagnosis of gemistocytic astrocytoma. And the report have suggested that gemistocytic astrocytoma may progress more rapidly than standard diffuse astrocytoma to anaplastic astrocytoma and secondary glioblastoma. We see in our pictures a large glassy eosinophilic cytoplasm and eccentric nuclei with perivascular lymphocytic infiltrate. Take-home message, I think first, EDH mutations are uncommon in patients younger than 18 years old and very rare in tumors of childhood. By current definition, all oligodendroglioma are IDH mutated. Due to its prognostic, diagnostic, and therapeutic impact, the IDH test may be must be performed. For the diffuse midline H3K27M mutate. It's a new entity, with a molecular definited with a mutation of K27A in the gene encoding the histone H3 in the context of diffusely infiltrating glioma with a predominantly astrocytic differentiation in the midline structure. We have an antibody, really very good antibody who help us. This antibody H3.3K27A, very interesting for neuropathologists. So diffuse midline glioma, H3K27A mutation is more associated with midline location than patient age. For glioblastoma, it's a multigenetic entity, but the new classification now defined by their EDH statute, we note that the novo glioblastoma have an EDH mutation in only 5% of case, and EDH 1 and 2 sequencing is only recommended when the patient are less than 55 years old, or we have a notion of low gradation. Okay. For glioblastoma, secondary glioblastoma, we have more and more other mutation, but the most mutation we see it, we have EGFR mutation in 70% with a loss of chromosome 10q and again of chromosome 7, and other mutation, the third mutation, PTN mutation, and other like CDKN2A mutation. For glioblastoma, secondary glioblastoma with EDH mutation, we note they have more frequently a TP53 and ATRX alteration. And other mutation, we have the alteration of MGMT promoter mutation or H3F3G34 mutation. The new classification not included this mutation, but I think it's very interesting for the future, for the diagnosis of juvenile glioblastoma. We have now for the new classification some of the histologic variant and pattern of glioblastoma included in the WHO 2007 classification have been removed. For example, glioblastoma with oligodendroglioma features who should varying of overlap with anaplastic oligodendroglioma. So we don't speak, we have not to give the diagnosis of glioblastoma with oligodendroglioma features, but now with the new classification, we add this new entity, epithelioid glioblastoma. It's a new variant have been added in this classification. It's occurred predominantly in the new young adults and children, and with a predilection location for in a temporal and frontal lobe, and we have for this epithelial glioblastoma, they carry a BRAF V600E mutation in approximately 50% of the case. No criterion was listed allowing a separation of this glioblastoma variant from anaplastic pleomorphic xanthoastrocytoma. For other astrocytoma, we have pilocytic astrocytoma is the most common pediatric brain tumor, accounting for 20% of all brain tumor. It's a circumscribed tumors with an excellent prognosis, can occur anywhere within the neuroaxis, but usually arise in the posterior foci. There is a well-established association of pilocytic astrocytoma and neurofibromatosis type 1, particularly those involving the optic pathway. Progression-free and over survival are influenced by several factors, including location, extent of resection. In some cases, the clinical course of the disease may be unpredictable with recurrence, progression, or dissemination in 10 to 20% of cases. We have most pilocytic astrocytoma have alteration in the mitogen activated protein kinase, so in the MAP kinase signalizing pathway. The most common genetic alteration found in the pilocytic astrocytoma is the activation of KA1949 BRAF fusion found in more than 16% of the cases. For pathologists, it's really easy the diagnosis to give neurosurgeon the diagnosis of pilocytic astrocytoma. We have a low to moderated cellularity with a biphasic pattern, compact bipolar cells with horizontal fibers, eosinophil granular body, very easy, and we have loose area with multipolar cells associated with microcyst. You add oligodendroglioma area and glomeruloid vascular proliferation. It's very easy, but if you have a little biopsy, simple biopsy, it's so difficult. So we have a profile, genetic profile, who can help us. The most common single aberration in the pilocytic astrocytoma occur about 17% of case is in truncation fusion of BRAF, and a highly relevant fraction of pilocytic astrocytoma, particularly those arising in the optic nerve, chiasma, and optic tract, is driven by underlying germinal mutation of in the NF1, and we have FGFR1 mutation found mainly in the midline pilocytic astrocytoma. This finding made pilocytic astrocytoma a prototypic single pathway disease and an excellent candidate entity for the therapeutic use of molecular target therapy, such as an inhibitor of MAC1 and 2. We have other genetic profile for pilocytic astrocytoma, like hedgehog pathway activation may be encountered in a significant proportion of patients younger than younger children, and we have other mutation. For example, for pilocytic astrocytoma, we have a deletion of P16 in more pilocytic of the brainstem and the spinal cord. We have for pilocytic astrocytoma have been found to lack EDH1 and 2 mutation, as well as histone HH3K27M mutation. What about pleomorphic xanthoastrocytoma? Is a rare brain tumor that usually occurs in children and young adults with an astrocytic differentiation, with an astrocytic proliferation neoplasm, with neuronal differentiation. This tumor corresponding histologically to a grade 2, and this tumor has a typically superficial location, and especially in the temporal lobe. The surgical resection is the mainstay of treatment. However, adjuvant therapy is sometimes necessary, and we found this BRAF V600E mutation is common in PXA, pleomorphic xanthoastrocytoma, and its presence in the absence of EDH mutation strongly support the diagnosis. The morphology is really heterogeneous. Appearance with spindle cells, arranged in fascicles, pleomorphic giant cells with eosinophilic granular body, large xanthomatous cells, and perivascular and intratumoral collection and lymphocyte, and a rich reticular network. But you see, it's very heterogeneous, and sometimes it's so difficult for us. But we have genetic profile for this xanthoastrocytoma, pleomorph xanthoastrocytoma. We have this BRAF V600E mutation has been demonstrated in 75%, and we can have this mutation with immunochemistry. So easy for us, and we have other mutation, other alteration. For example, we have chromosome 9p loss with coincident homozygous deletion involving CDKN2A and CDKN2B. Lossy has been encountered in 50% of cases, but we found a low incidence of P53 mutation. In conclusion, in summary, many of these molecular entities will be in the future, in the event of tumor neuroresection, subject to target therapy rather than to radiotherapy, conventional chemotherapy. Therefore, the molecular stratification of this tumor should be considered as a diagnostic standard. The clinician and pathologist will be better equipped to effectively diagnose and treat these tumors. In addition, better molecular knowledge will be used in the future development of new therapy. Before I finish, I give you this Robert Anson Henley proverb: everything is theoretically impossible until it's done. Thank you very much.
Thank you, Fela, for this amazing presentation. I think that you will have some questions at the end of the webinar. Theoretically, we should have the presentation of Professor Kliba, but it seems that he has a big problem. So we will move to the presentation about awake surgery, which will be done by Professor Abdelrahman Tikanouine. Professor Abdelrahman Tikanouine is a professor of neurosurgery at the specialized hospital of Selim Zmirli here in Algiers. And he's also professor in neurosurgery at the University of Medicine of Algiers. He is, I must say that he is Mr. Awake Surgery in Algeria. He has worked a lot in this field in our country. He is, I think, the pioneer of this. He was with Hugues Dufaux, and he has made a wonderful job about that. So, Abdelrahman, you have the talk. You can share the screen. Is it okay? Okay. Nabila, micro.
Son micro est activé.
D'accord.
Mais on n'entend pas.
Abdelrahman, do you hear us?
Non. On vient de l'essayer. Hein? We just tried and it worked.
Yeah, it's okay. We are hearing you here. Please. No.
Faut augmenter le son.
Yes. On a entendu Gnen. So maybe, Abdelrahman, maybe
we will have to reconnect.
Okay.
Maybe they have just to reconnect.
Yes, Abdelrahman, you just have maybe to reconnect. So we will move to the next presentation, and after we will go to you, okay? Just maybe you have to reconnect you.
Je vais les appeler par téléphone et je vais expliquer.
Okay, Nabila will call you.
Yeah.
Okay, so the next presentation will be done by Professor Tanju Utsar from Antalya. He's a professor at the Academy's University Medicine Faculty of Antalya. And his specialty is functional neurosurgery and neurotrauma. And he will talk about, he's also a member of the Education and Training Committee of WFNS. And he will talk about intraoperative guidance in surgery of glioma. Professor Tanju?
Thank you very much. Can you hear me and can you see me in good?
Yes.
Okay.
So you can screen, you can.
Yes, I will share my screen.
Okay, you can share your screen.
Good evening, my colleagues, my friends. I hope everything is good in health in these difficult days. We are now passing hard days, but I think we will win our fight. Today, I'm going to say something about some tools, some technical devices, some technical instruments who is helping us, who is helping neurosurgeons intraoperatively, perioperatively, postoperatively. Actually, this is a little bit technical information, and I will tell some very brief information with these things. Sorry. As we know, the development of image-guided neurosurgery represents a substantial improvement in the microsurgery of tumors, AVMs, of other intracranial lesions, and we have a lot of new technologies, new tools that's helping us to perform a successful surgery with a greater ease, accuracy, and efficacy. There are a lot of assistive techniques described, such fluorescent guided resection of gliomas, such neuronavigation systems, intraoperative MRI, intraoperative CT, or intraoperative ultrasound, stereotactic procedures, frameless stereotactic procedures, neurophysiological monitoring, robotic surgeries, etc. All have provided us all we need for good surgical results. Additionally, some functional imaging modalities such positron emission tomography, SPECT, DTI, functional MRI can be used in order to reduce neurological deficit resulting from surgery. Let's start of these technical tools. Neuronavigation systems. All we know of these systems, I think many of us are using the neuronavigational systems. The key step for the use of neuronavigational systems is the generation of 3D pre-op image data merged with the patient anatomy by registration. It can be divided frame-based neuronavigational systems and frameless neuronavigational systems. Frame-based systems, as also known stereotaxic systems, is a very classic systems, and it has got some advantages. It has been used for many years. The most important advantage of these systems is being extremely accurate because of rigid head frame is fixed to the skull. The stereotaxic systems is increasingly being used in tumor biopsy, for stereotaxic biopsy, for deep-seated lesion surgery, and also more common use in the functional neurosurgical procedures, such DBS surgeries, such Parkinson's surgeries, the dystonia surgeries, movement disorder surgeries in a huge area. And it has got some disadvantages because many of us know that the frame placement is a difficult procedure for the patient, and it's a painful procedure. Actually, we are using a local anesthesia, but it is not good comfort for the patient. And also, time is important for calculate the real and correct trajectory is the problem of the stereotaxic frame-based systems. Frameless systems, if I'm not mistaken, many of us are familiar with the systems. These systems, in contrast to frame-based devices, track to the movement of surgical instruments in space by optical, ultrasonic, or electromagnetic sensors. And their position to the lesion can be projected from pre-op image, but not in an intraoperative real-time modus. This is the disadvantages of the systems, and they require CT, MRI, and preoperative CT, preoperative MRI pictures. And because of that, they have some they include some errors. The registration may be inaccurate because of scalp movement geometrical distortion and the patient's movements to the respect to the systems during surgery. These are the disadvantages of the frameless systems, but we all use very widely in our practice. Intraoperative MRI are another technical tools helping us in intraoperatively. Where this system is a procedure to create images of brain during surgery. And it allows us not only to increase the extent of tumor resection and to preserve eloquent areas, but provides a physiological and biological data of the brain tumor tissue, as well as the intraoperative detection of complication. I don't know how many of us have got intraoperative MRI in our practice, because it is a really expensive system. But if you have, it's going to be very, very useful systems. But it has got some disadvantages, because locate abnormalities if the brain has shifted. I'm sorry, I'm telling about the advantages of the intraoperative MRI. Locate abnormalities if the brain has shifted, and differentiate abnormal brain tissue from normal tissue. Another area is intraoperative ultrasound. I think at least in our center, we are commonly using intraoperative ultrasound. It's a useful tool for guiding the resection and improving the extent of the resection. You can use ultrasound preoperatively, intraoperatively, and also postoperatively. What is the advantages? What is the benefit of ultrasound when you compare the frameless systems, such as navigate on real-time images? It is giving us a real-time images, and it's visualize the brain shift and acquire images faster. And intraoperative ultrasound can be combined with other technologies together. I am running quickly because all topics is a really huge topics. That is why I'm trying to say only some important words, some basic words, all these techniques. Tractography, another helping tools for us. As we know, the goals of our surgery is avoid the damage to eloquent areas of the brain. Tractography remains the non-invasive method capable of segmenting the subcortical course of a white matter tract. DTI is increasingly used in pre-surgical mapping in tumors located in eloquent areas, such as very close to motor cortex. Correct preoperative identification of white matter tracts is very important as the identification of tractography in pre-surgical planning to us. You can see the relation, the white matter tracts and the pathology with tractography preoperatively, and then you can plan your surgical entry zone and the extension of your surgery. The DTI and the fiber tractography are MR imaging techniques based on the concept of anisotropic water diffusion in myelinated fibers. This is the main philosophy of DTI, and it enables 3D reconstruction and visualization of white matter tracts, and gives us information about the relationship of these tracts and the tumor on the pathology. Actually, we can combine all these technological devices or these technological improvements together, such the combination of image-guided neurosurgery, combination with functional MR imaging, nuclear medicine imaging, physiological examination. It's actually maybe it's a new area, new methods to allow us the fast orientation of the lesion to functional anatomy. You can combine all these methods together, such a neuronavigation system, nuclear medicine treatment, computer tomography, or the DTI and functional MRI. You can combine. If you have a tools on your center, you can play with them together. Not you don't need to work only one things. You can combine all things if you have. This is important. The another things is fluorescent guided resections. It is important for glioma surgery for the neurosurgeons. As we know, fluorescein is a widely used tracer for many applications. And fluorescent guided surgery is especially a specific microscope filter is becoming increasingly in worldwide. What is the philosophy of the fluorescent guided surgery? It is capacity to accumulate in cerebral areas where there has been blood-brain barrier damage makes it particularly suitable as a dye for the interrupt visualization of malignant gliomas. There is some advantages of fluorescent guided surgery. Firstly, the quality of visualization of the surgical field is really excellent. Another important advantage of the fluorescent guided is the availability and accessibility of fluorescent. It is very low purchase cost. Maybe if we compare with 5-ALA, fluorescent does not require prevention from light, and no severe reactions have been described with fluorescent guided surgery. And furthermore, it is completely excreted within 24 hours. This is a simple example of this fluorescent guided surgery. Here you can see the tumor. This is the axial MRI pictures. In the surgery, without fluorescein, actually we can differentiate the pathology. This is very cortical pathology because you can see the cortical pathology with white light, and when you give the ultrafluorescein, the age of the pathology is very clearly demonstrated, and you can go easily with big comfort, or like this lesion. When you give a fluorescein, you can see the pathology very well. Then we are running step by step, and we are coming to the technologies. The robotic surgeries, I'm going to say something about robotic surgeries and maybe virtual reality, but I think these are now it is a little bit far from the general neurosurgery practice because it is not commonly used. It is very expensive, and in my personal opinion, we are not sure what are they doing now, what are the results, but that's why we have to know some words about that. Robots are more routinely, non-remotely for precising and carrying out some certain procedures, such skull-based procedures. And in the recent year, the robotic surgeries numbers is slowly increasing in some centers if they have. There are some different robotic systems, but mainly we can classify it in 3 type of robotic surgery systems. The one is telesurgical robot. The second one is the supervisory surgeon controlled robot. And the third is handheld shared control systems. I'm not going to go in details. I think this is important. It is enough for us. There is hope that robotics will eliminate mechanical errors, reducing operating time, and provide the same or even greater resective margins with minimal access surgery. And the final words of this topic for robotic surgeries, despite we can see some positive steps in this direction, there is still a long way to go. owing to the anatomical complexity of the brain and spatial limitations inherent in neurosurgical procedures. The last topic of my presentations is virtual reality systems. It is, I think it's not familiar to us. Some centers in the world doing this kind of surgeries. I'm not sure where exactly. The neurosurgeons typically rely on imaging displayed in 2 dimensions. This is our characteristic. We imagine the pathology in 2 dimensions and reconstruct these images mentally into 3D in preparation for surgery. The virtual reality is helping us on this field. When the imaging modalities become more numerous, such CT, MRI, and more complex functional MRI, DTI, the ability of the reformat these images mentally in our brain 3D becomes increasingly and challenging. An important aspect of successful neurosurgery is a careful preparative planning, because during brain surgery, the neurosurgeon must navigate safely through a highly complex 3D space. And since the brain architecture is often highly distorted by the underlying pathology, intimate understanding of the relationship of the pathology to normal microanatomy is crucial for us. That is why the virtual reality in this field can help us for imaging of the pathology in 3D imaging of the pathology in brain in this field. I think in the next future, it is going to be more commonly. Yes, this is some picture of 3 virtual reality surgical procedures. Before I finish my presentation, I would like to say that I believe that we will back our free life. We will back our normal life in very quickly, in very future. Thank you very much. Good evening, all. It's finished.
Thank you, Professor Tanjum. Thank you. A wonderful presentation.
Thank you very much.
Thank you so much. I hope you will be with us for the questions, because I know that some people will ask you about some things that you talk about. Thank you.
Yeah, well.
So I hope that we can move to the presentation of Abdelrahman Tikanouine. Is it okay now? Nabila?
Non, oui, très rare. Il faut rétablir. C'est bon. Partage l'écran. Non, passe pas.
Is it a problem of connection?
I think it's the same problem. Can we?
Abdelrahman, do you hear us?
Non, on ne te voit pas. Non, je pense qu'on devrait passer à la suivante.
Okay. So Isabelle?
Can you hear me? Yeah, I'm here.
Are
yeah,
you
and
here?
I am.
Okay.
And I'm sharing my screen.
Okay, thank you.
Pour activer.
So Professor Germano will talk about a topic, very interesting topic, which is technology and artificial intelligence in the gliomas and It's a compliment, I think, of the presentation of Professor Tanju. Isabel?
Thank you very much. Again, I really appreciate Shukran for the opportunity to be together with the Algerian Neurosurgical Society. Thank you, Professor Tanju Ukar, for the beautiful, beautiful, inspiring lecture, and also for the previous speakers. These are my disclosures, and I was asked today to talk about technology and artificial intelligence, which naturally is a nice thing to talk about, because we know that neurosurgeons have pursued many avenues for improving technology in the neurosurgical field. And I think that this slide is summarizing how visualizing the operative field is important. So Cushing was the first to introduce the pathological review of tissue. Dandy introduced the air contrast radiology. Moniz introduced the way to visualize the vascular content on enhanced radiography. And finally, Sir Victor Horsley introduced the stereotactic instrumentation that is really the basis of what Tanju showed with the intraoperative guidance and all the beautiful work that he has been doing. And technology keeps on helping us and or invading our field, right? So if I asked this question 4 months ago or a year ago, what is the baby's first word? I think that in most languages will be something that sounds like either mama or dada, either mother or father, but not anymore. This article came out just a little while ago showing that this baby's first word was not mama, was not papa, but was Alexa. And why is it Alexa? Because technology is here to stay. Technology is with us. A lot of people have this device called Alexa, and the baby hears it, and the baby says that as the first word. So technology is something that we embrace. Does not mean that if you don't have technology, you're not doing good neurosurgery. I actually believe that is quite the opposite. I think that first you're a great neurosurgeon, and then you embrace and endorse technology. And I also don't believe that every single gadget that is on the market is something we need in the operating room. I very much believe into the fact that no matter where you are, New York City or Algiers or anywhere in the world, the resources we are working with are limited. There is no such a thing as thinking that there is an unlimited amount of resources. And especially when we take care of brain tumor patients, we need to understand what is the economic burden of the disease. And I think that there are three very important factors here. We as neurosurgeons can help by having an impact on the death rate. And can we provide a cure for high-grade gliomas? The answer is probably not. But can we postpone that death? And by so doing, can we really improve the economic burden? The second question is, can we help with the neurological disability? And the answer is yes. We can restore the neurological function and we can avoid neurological deficit. And by so doing, when we perform the surgery for high-grade gliomas, those patients will do better. They will have a better quality of life, but also for what society is concerned, we decrease the burden of the disease because those are still going to be patients that can continue to function. And finally, what is really the treatment cost? And it is very important to focus that we want to obtain patient-specific treatment, that although in order to develop those treatment, it might be costly, but then when we figure out what is the best treatment for each patient, and this is very much apropos of the beautiful lecture on pathology, right? So when we know what is the specific treatment for a molecular signature of a high-grade glioma, that treatment will be beneficial to that patient. And in essence, there will be less money that is wasted. And so three concepts on how can we look into this for brain tumor surgery, that is. The first one is when you perform surgery for brain tumor, is what you see, what you get. And the second one is the truth of today, the truth of tomorrow. And then the final one, are there any new scalpels that can help us? So let's look at the, is what you see, what you get. So we do know that giants of neurosurgery, such as Professor Yassergel and Professor Malice, introduced the microscope. And the reason why they did that is because it's very important to be able to see what we do. What is a microscope? Everybody knows what a microscope is, but the wording comes from the Mediterranean area, scopeon, to look at, and it does allow us to increase the magnification and therefore to see better. Now there is a new gadget on the market. It's called the endoscope. And I know that Professor Swad Bakhti and other Algerian neurosurgeons perform beautiful endoscopic surgery. And that is a tremendous addition to the pediatric neurosurgery and also to some of the adult neurosurgery that we do. This is in contrast to the exoscope. So what is an exoscope? An exoscope is a way that you can actually put a camera over the patient and then go, I don't know if this movie will play. And if not, you can just copy and paste. Maybe it will play. But basically, you put that camera over the patient and then you will see that increased in size on a screen in front of you. And that will sometimes be very much helpful because it doesn't have to distract you as you are performing the surgery in constantly sorry, this is not showing that, but here it goes. Basically, it does allow you to show that anatomy at much a higher level of magnification. And the robot that is just above you, I can get into this in any event. The robot that is just above you allows you to be much more precise in the visualization of your instruments because the robot now is moving. Whoops, sorry. Sorry. I can get out of this. I am not sure what just happened. This is just perfect for a talk that talks about technology, right? So let me just close that. This is just embarrassing to show that actually technology can take over my computer without my being able to turn it off. I think that I got rid of that. But by so doing, we're going to go back to the simulation, and we were talking a little bit about the simulation already. And so what is really simulation? Simulation is when we can take the preoperative scan and overlap it with the patient's anatomy. And this is what we do now, where we have these big screens in the operating room, and then we can enlarge and or decrease. But as you heard before, it's done on 2D images. Whereas with the virtual reality and the simulation, what we can do now is take that 2D image and overlap it in a 3D image on the patient's anatomy and or brain. And so we can basically see ahead of what we're doing. So we can see the tumor through the hair, through the scalp, even before the cut is made. And on a separate screen that gives us a 3D representation, we can see the trajectory through the microscope and through the exoscope. Let's go to the truth. What is the truth? That's a big question. So I think that one definition of the truth is that the truth relies a little bit on what we know. And what we know is very limited. So clearly humans know more than, let's say, cats or other animals, but still our knowledge is limited by the big number of information that is growing around us. And this is why artificial intelligence can possibly help neurosurgery the same way that artificial intelligence is helping other fields, like for instance, finances and industry and other activities. There are three types of artificial intelligence. One is analytical. So these are softwares that learn from past experience. The other one is human inspired. And so that understands and apply human emotions. And then the last one is the humanized artificial intelligence. And that I think is more of a Hollywood product. So I will not talk about that yet. But the first two, especially the analytical, is what we can bring into the surgery for brain tumors. So basically, the type of artificial intelligence that can help us is that enables us to provide computational power to create cognition in machines. And where is that computational power coming from is based on the analysis of big data. The data around us is growing as we speak. So this is a slide that shows the difference between 2013 and 2020. So it's only 7 years, and most of you will remember what it was like 7 years ago. And the data was much less than now. And why is that? Because especially in healthcare, we have all these new gadgets that are coming in. For one thing, I think most of us are carrying a cell phone, and there is a lot of information in the cell phone. Electronic medical records, a lot of countries and or cities are using the electronic medical records. The wearable, right? A lot of people, I don't have one, but I know a lot of people have those wearing gadgets. And so those are also giving us information. And finally, the human genome sequencing. Look at how many kilobytes of memory that is. And this is something that we've heard from the first speaker that is very important for neuropathology as well. So what part of artificial intelligence is the one that can help the neuro-oncology community? I think it's the part that is called machine learning. Machine learning, as you can see in this cartoon, it is a current application of artificial intelligence that is based on a field of computer science that gives computer the ability to learn from big data without explicit programmation. And so what does that mean? And then there are two more other parts that come after machine learning. One is neural network, and the other one is deep learning. But let's just focus on machine learning. On machine learning, there are three ways that that computer can learn from big data without being programmed. One is support vector machines, random forest, and Bayesian network. I don't want you to get confused with these words. I just want to introduce the words. So what it means is that you tell the machine, if you're doing a supervised learning, okay, this is what I want to know. I'm going to give you, computer, these 10 patients. And I want you to tell me at the end, based on all the factors that I'm putting into the computer, whether or not this patient has a high likelihood of having a myocardial infarction or not. And so first you teach the machine and you give them a sample and you say, see, this patient had yes for this, no for this, yes for this, no for this, and had an MI. And the other patient had the opposite and did not have an MI. So you're teaching the machine how to interpret the data. And then after that learning is done, a preliminary learning, you can input a number of patients and the machine will be able to do it for you without your input. Right? And so this requires an input and an output pair match. So you have to tell the machine, what is the scope? What do you want to learn from that data? And this is different from deep learning because deep learning instead is learning unsupervised from data that is unstructured and or unlabeled. So if we go back to that example right here. In this example, now what we would do with the machine is we're gonna put 100 patients in, but we're not gonna tell you whether or not we want to know if the patient had a myocardial infarction or not. We want you, machine, to tell us what kind of patterns do you see. And you can imagine that for brain tumors, this will be incredibly important. And I will show you some examples. So what we looked at was machine learning in neuro-oncology. If data analysis, when we published this paper, it was only 5,000 patients that were used to look into artificial intelligence, that were really changing the decision-making paradigm. And what we found was that there actually were studies where machine learning was able to predict the outcome of patients with brain tumors with a sensitivity that was ranging between 78 and 98% with a high specificity as well. And that machine learning algorithm had a higher accuracy than conventional one. And the same thing for image analysis, it did show that accuracy in diagnosis low grade versus high grade glioma range from 80 to 93%. And when we were looking at high grade glioma, comparing them with primary CNS lymphoma, that number was even higher, to 90%. And finally, there was also the possibility that machine learning could be used for gene expression in neuro-oncology. As you can see here, there's been a booming of articles showing how artificial intelligence can be used as an outcome predictor, as an image analysis, and as a gene expression. And why is it so important that it is used as an outcome predictor? Because of the first slide or so that I showed you, right? Because we're trying to really decrease the burden of disease, in the sense that we don't want to use treatments that are not appropriate for patients that will not benefit from it. It's not just an economical value, but it's also a quality of life, because if the treatment is not efficacious, then the patient could have side effects from the treatment that could be otherwise reduced. And here are the tables from that paper showing again that the machine learning methods was varying among the studies. So now let's talk about radiomics. What is radiomics? Again, is the application of artificial intelligence to interpret the images. And here you can see how a multimodality MRI is entered into the computer. There is a segmentation that is done super fast, much faster than we could do manually. And there is a feature extraction. And then the machine is actually doing two different things. One is constructing a predictive model. And second, by looking at molecular markers on the MRI itself, can give us a survival prognosis. So would it really make a difference if I already knew ahead of time before going into surgery, hey, you know what, this incredibly large tumor you're about to take out is in somebody that is IDH wild, MGMT not methylated, and ITRX retained? And the answer is yes, because probably, you know, doing a very long meticulous surgery in that particular patient would not be as meaningful as in a patient that has a much better survival prognosis. So I think that this, what I'm telling you tonight, might be proven wrong in the future. But if I had to bet, I think that this is what we would use this information for, right? And the other field or niche in neuro-oncology for artificial intelligence is to be able to differentiate pseudo progression from real progression. So what is pseudo progression? Pseudo progression is tumor enlargement on sequential images after treatment. And there are basically different type of enlargement on the MR images. One is the real progression that is here in red, also known as hyperprogression. And then we have a pseudo progression, which means that as a result of the treatment effect, the area of abnormality on MRI is increasing, but then it will continue to decrease. So it was not real tumor, but was treatment effect. And then in contrast to that, we have a durable complete response, which is a tumor that responded to the treatment, as opposed to a tumor that shows only partial response and then in the future might continue to grow. We're all familiar with the STOOP protocol. This was published in I don't remember the exact date, but many years ago. And we know that it showed that patients that are treated with radiation with concomitant temozolomide do much better. And actually there is a subgroup of patients that have a methylation of the MGMT promoter that have even a better survival than the entire group. Here is how it's given: concomitant during the radiation, and then a pause, and then at least 6 other cycles. And what we and other people have, authors have shown, is that because of the TMZ concomitant with radiation and or other treatment like immune therapy, we see a lot of the pseudoprogression. So here you see a patient that I operated on and has an immediate postoperative MRI that shows a gross total resection. And here is just a few weeks after the concomitant XRT and TMZ. And the real question is, what are we looking at? Is this tumor really back, or are we looking at pseudoprogression? What is pseudoprogression? Well, our changes in response to therapy, they could be due to cytotoxic edema, they could be due to vasogenic edema, they could be due to apoptosis and necrosis, which is really a desirable effect of the treatment. And they can also be due to immune cell infiltrate, which again might be beneficial to ultimately induce a shrinkage in that tumor. But we don't know that up front. And so this is how the artificial intelligence could really help us, because we could have a much better understanding of all the points of pseudo progression. And so here is how that would work, right? That you put the image into the machine and you're performing what we can also refer to as a virtual biopsy, where the actual computer is based on all the information that is inserted before and the experience that you have with these patients, that could tell you, you know, this is a true progression and therefore you need to either perform a treatment change and or do surgery, or this is a pseudo progression and you should continue the treatment. And again, going back to that very first slide, looking at the economical burden of this disease, if we know ahead of time what is the correct course of action, we're saving a lot of money and we're really helping and hopefully improving quality of life and survival of our patients. Here's another great example of the use of artificial intelligence in neuro-oncology. Our pathologists do know that intraoperative frozen section can be very challenging for many reasons, for brain tumors, that is, including the fact that the brain is much less malleable to freeze, and there are frozen artifacts that can really alter that anatomy. And so if you really need that frozen section to know how to continue the surgery, sometimes you can be misled by the artifacts on the frozen tissue. Whereas if we use artificial intelligence, and Raman spectroscopy is actually a step before artificial intelligence, because it's really using energy of photon in and energy of photon out to process that tissue. But then that is all processed by a computer, or can be processed by a computer. Then the accuracy of our intraoperative diagnosis can be much higher, and again could result in a beneficial prognostic and therapeutic effect for our patients. And so the last 2 minutes or so, I want to talk about, you know, the fact that maybe scalpels are not the only thing that we have. And so again, here is our humble reality, or at least my humble reality. Every day when I operate on a patient with a brain tumor, I feel really great because, you know, like in this case, it's a patient with a glioblastoma comes in, I take the tumor out, I looked at that postoperative MRI and I'm incredibly pleased. And then 14 months after surgery, the tumor is back. So as a surgeon, this is very, very humbling. And I always wish that we could help our patients with something more than just the knife. And I think that there are many barriers, including the blood-brain barriers and the fact that there are glioma stem cells that we have to fight for those tumors not to grow back. And so the technology, how can technology help us? Well, what I've been looking at in the laboratory is the potential use of human-induced pluripotent stem cells. And this takes a lot of technology, but now is much more available than, let's say, 10 years ago. We started some of this work with embryonic stem cells that now are obsolete. For many reasons, beside the ethical reason, also because they are much more costly and much more difficult to obtain, whereas the induced pluripotent stem cells originate from a fibroblast, so they can be taken from the skin of a patient. The cartoon that I'm showing now is that of the original dedifferentiation of a fibroblast into a pluripotent stem cells. And now we know that we have published actually that we can induce that dedifferentiation, avoiding the oncogenes such as CIMIC. And so that makes it possible for use in humans. So here are our results. We use the human-induced pluripotent derived astrocyte population. You can see that these are really astrocytes that can fully integrate and carry genes within the nervous system. I think we published this in 2016, or I don't know, but you can see it at the bottom there maybe. And that when we load a gene into that induced pluripotent stem cell, the cell is capable of carrying that gene throughout the brain. And you can see that this is implanted in one side. We implant in a mouse the tumor on the other side, and these cells are crossing freely on the other side, and they go attack that tumor and bring in that apoptotic gene on the opposite side. So is this science fiction? Hopefully not. Hopefully this is not science fiction. Is this going to be a panacea for all high-grade gliomas? Absolutely not. But this, once again, is to show that we need to keep an open mind to all the technology that is available to us in the operating room, outside the operating room, and in the laboratory. And so this is what we are hoping to achieve, and that is when the patient comes in and has his first surgery for the brain tumor, we will also take a little skin biopsy. We will start inducing those pluripotent stem cells. We will include a killer gene. In these slides here, I have that the Alzheimer gene can also be included in this, has nothing to do with brain tumors, but this was just to show that the concept could be broader than just neuro-oncology. In the US, we have a high number of patients with Alzheimer's, just to show that this technology is for all of us involved in taking patient with brain disorders, not just for brain tumors. And then those cells can be cloned and engineered to carry a pro-apoptotic gene. And when the patient comes back with a recurrence, as I showed you in the slide, 14 months later, or whichever how many months, then the tumor is resected again. And now we can implant that iPSC with a gene, a pro-apoptotic gene, and hopefully use that as a potential fighter for the recurrent tumor. And so with that, I thank you very much for your attention and for the opportunity to be here today. Shukran.
Thank you, Isabel. Thank you for this outstanding presentation. Really amazing. And that's maybe, as you said, science fiction, as we said in French, you know. So now I hope that the problem is solved with Abdurrahman. Yes, we hear him. So it's good. Okay.
C'est bon?
Très bien.
Hello everybody, I am happy to be here with you today. My main interest is awake surgery since 2007, and I will be presenting my experiences in awake surgery in gliomas. But I prefer to talk to you today about my first 108 patients out of nearly 400 patients I have operated, because we want to show you the difficulties you may encounter when starting your experience. Surgery is the first treatment in neuro-oncology. However, cerebral gliomas, mostly near or within to so-called eloquent areas, represent a challenge of effective surgery because of the risk of even occurring functional disorder and congruous with adequate socio-professional life. An account of anatomical functional variability observed between individuals and cerebral plasticity phenomena, it has become possible to consider broad tumor resection in condition performing a mapping of the reorganization of cognitive function related to the glioma. The cortical and subcortical electric stimulation carried out during surgery, mostly on awake patients, allow releasing surgical resection extending to the limit of eloquent cortex and pathways. Dysfunctional resection are planned pre-operatively using anatomical MRI and, if possible, the functional and the DTI MRI. The preserving of the fraction is obtained during the gesture by means of direct electric stimulation. Mapping of brain function. We will see now the brain mapping. We have many techniques about pre and per-operatively. It's about intracranial electrophysiology, positron emission tomography PET and MEG, functional magnetic resonance imaging, anisotropic division tension imaging or DTI MRI, and intraoperative cortico-subcortical direct electric stimulation, still considered by several others as the gold standard of brain mapping. Technique description. All patients underwent awake anesthesia to allow function cortical and subcortical mapping to be carried out using direct electric stimulation. This method included the electrical parameters and the intraoperative clinical task. We used the bipolar electrode with 5 or 6 millimeter space tips delivered and biphasic currents. Delivered a biphasic current, pulse frequency of 60 Hz, single pulse phase duration of 1 millisecond, amplitude from 2 to 8 milliamperes. In the first stage, after tumor and circuits and gyrus identification using sonography, cortical mapping was performed before resection to avoid any damage to eloquent area. Sensorimotor mapping induced movement or paresthesia in the contralateral body. For motor mapping, it's possible to do direct electric stimulation under awake or general anesthesia protocol. Under local anesthesia, the patient will ask to perform counting regularly from 1 to 10 over and over, and picture naming preceded by a short sentence to read, namely the French translation. This is a imaging study. The study of imaging is our roadmap because it enables us to have a pre-operative knowledge of all function areas near the tumor, the functional pathways in the region, and analyze the deep gray structure clause concerned by the glioma. Thus, we will have an idea on what should be preserved. For the frontotemporal insular glioma, the areas that should be stimulated and preserved if they are functional are in the cortex. In the first stage, the sensory motor areas are stimulated to confer positive response. In the second stage, the cortex infiltrated by the glioma must be non-functional, otherwise non-resection is possible. Next, we should study the redistribution of the functional of Broca's area, pars triangularis and pars orbitalis, the ventral premotor cortex, the prefrontal cortex, the Wernicke area and its extension, the limit the function of the operculus. The wall constitutes the cortical limits of the resection of the glioma. After resection of part of the glioma in the subcortex, by stimulation, we have to find and preserve the following pathways: arcuate fasciculus above the glioma, inferior fronto-occipital fasciculus below it, optic radiation posteriorly and inferiorly. The incinate fasciculus will be partially or totally resected when doing temporal polectomy. These pathways constitute the limits of resection. We must not forget that some structures may be infiltrated by the glioma but may maintain the function because the cerebral plasticity didn't quite work. The structures are the insula itself, the head of caudate nucleus, the lenticular nucleus. The presence of function will prevent us from continuing the resection. At the end, we should be able to find by stimulation the internal capsule and the corona radiata. These structures are considered the deepest limits of resection. And of course, we do our vascular study. In conclusion, it's once all of this study conclude and all the information integrated in the surgeon's memory that the per-operative mapping can be successful. We will show now a video of 3 minutes that will briefly show you the principal steps. First, the large bone flap needed for mapping, infiltrating of the dura by local anesthetic before waking the patient. We use ultrasonography to determine the tumor boundaries. Next, establish the cartography of function around the tumor and on it with the help of the psycho-orthophonist. On the cortical cartography done, and there is non-function in the tumor, we start the resection. The patient will continue the test. When the volume of the tumors is smaller and we are near the limit of the tumor, we stimulate again to look for the pathway. The resection of the tumor will be ended and should be maximal. Result: mapping characteristic. According to our roadmap, the completion of our mapping was complete in 66% and incomplete in 34%. By having a look at this chart, the reasons of incomplete mapping were: first, the langage pathways not found by stimulation; the second, the corticospinal tract indeterminate. Therefore, the use of the DTI MRI is advisable. Third, there was function left in the tumor, so it would be more suitable to perform a preoperative functional MRI. Another remark: all of cortical function were found and there was no negative. According to European Association of Neuro-Oncology that published a meta-analysis in 2015, below found the language pathways in 58% of cases, Sanai in 59%, Smith in 35%, Mitberger between 36 and 100%. For us, in 108 patients, we found it in 53% of cases. The mapping could be incomplete for different reasons. Insufficient training in first, the lack of sensibility, and the lack of specificity for some others. In a multivariate study on the cartography efficiency, we found that the mapping in a weak protocol was more successful than general anesthesia. For the location of glioma, the more the glioma is profound, the more the mapping is unsuccessful. The volume of glioma was of no influence. Study of extent of resection. We found total and subtotal resection were mainly incomplete mapping, respectively 1 and 65%. Partial resection in 33% of cases, more importantly when mapping was incomplete. Biopsy 1% because function in the tumor. In conclusion, the complete mapping was in favor of a more maximal extent of resection. Function evolution study. We noticed that there was a progressive improvement of function with times. In post-operative period, 85% of patients had Karnofsky score less 80. And to 12 months, we had 91% of satisfactory result, Karnofsky score between 80 and 100. What were the influencing factors on the evolution of the function? Quality of the mapping, extent of resection, physiotherapy and its timing. However, location of the glioma and histological grounding didn't have any influence. Tumor recurrence. During a median follow-up of 5.3 years, we found 60% of cases had stable residue. 41% had active progression after remission. 6.4% with the progression without remission. 31% of patients were reoperated. The rest were followed up regularly. According to the Cook's regression, the grade of the glioma is more influential of the recurrence than the extent of resection by nearly double. According of study of the survival according extent of resection. According the Cook regression model, the ranking of the risk factor of the survival is as followed: histological grading, partial resection, age, volume. However, the timing of chemotherapy has not significant effect on the survival of anaplastic glioma. The location did not influence it. Conclusion, recommendation. First operative time, bone flap, need to be done quickly to reduce the dosage of drugs used. Maximize the use of the actual technology. Use the functional MRI to check the functional redistribution of the, and to eliminate the presence of a function in the glioma. Do a DTI preoperatively to evaluate the degree of the pathways deviation, and if possible, do per-operative tractography. Try to determine the threshold of pulse intensity by using the transcranial magnetic stimulation preoperatively. For your first patients, choose the glioma's location wisely. We recommended to start with the premotor glioma, and women are more cooperate than men. Determine the irritable personality after a complete examination by the psychologist or even a psychiatrist. Don't leave the patient a long reflection time before operating to avoid the death. Thank you very much.
Thank you, Abdurrahman. Thank you for this.
Thank you,
Thank
Dr.
you, Abdurrahman, for this
Professor Bakhti. Thank you.
outstanding experience and, as always, a very honest presentation. And I said that before. You are Mr. Awake Surgery in Algeria, definitely. Thank you so much. So as I said before, we have a problem with our colleague Suhail Tliba. There's a big problem. He will not join us. And I will talk. So I will make the last talk about, of this webinar. I will share my screen. Is it okay?
Yeah, it works.
It works?
Yes.
Okay. Okay. So I will have the difficult task to talk about pediatric glioma surgery. And it is the work, as you see, which is done by the Pediatric Neuro-Oncology Group of Algiers. We are many specialists, neurosurgeons, pediatric oncologists, radiotherapists, pathologists. Our pathologist is Filla. And as always, I begin my presentation to say the child is not simply a small adult. Because we are dealing with a brain which is in continuous growth and in maturity, which is explained that the pathology is not the same, the biology is not the same, and the consequences are not the same also. The gliomas, as everybody knows, are the most common CNS tumors in children. We have several pathological subgroups. The location is very, very important because it will have many consequences. And because we are dealing with children, we have many factors that are limiting the treatment. When I talk about the treatment, is all the management with surgery, chemotherapy, radiotherapy. Of course, surgery is the main treatment of these gliomas, and the extension of resection is a very, very important prognosis factor in this pathology. But we have also to deal with the quality of life in these young children, and this is also very important. And fortunately, these last years, we have a better knowledge of molecular biology that mean that maybe we will have many tools to treat these gliomas. So these pediatric gliomas are divided, as you know, in pediatric low-grade gliomas, which are very common, which are grade 1 and grade 2 of WHO classification. We know that there are many diseases that predisposes children to that, as neurofibromatosis type 1. And we know that this pediatric low-grade glioma are mainly a RAS-MAP pathway disease. The cerebellum is the most common location, and this location of these gliomas correlates with the histological type, with the effects of symptoms, and the resectability. The surgery, as I said, is the cornerstone of the treatment, and you can see that gross total resection can be achieved in nearly 70% of the cases. And also we have PFS and overall survival rates of near 99% and 94% at 5 years. For the high-grade gliomas, they represent nearly 10% of pediatric brain tumors. And we know that there are also some predisposing factors such as Turco syndromes. And unfortunately, the majority of these high-grade gliomas are in the brain stem. Of course, the histological features are identical to adults, but the biology is totally different. For imaging, of course, my colleagues talk about imaging before me. MRI is the gold standard, but the most used sequences are T2, T2 flare, T1 post-contrast. But we have also the perfusion, the spectroscopy, which may be very helpful, but are not done routinely in all the centers. Of course, DTI is a very important tool, but unfortunately, of course, not all the departments can have this DTI. And you can see these wonderful images that show, excuse me, that shows the location of the tumor inside the different fibers and corticospinal and associated tracts. And what about functional MRI? My colleague have talked about this functional MRI before me, but here we are dealing with children, and maybe functional MRI is not always feasible in children. These are the factors that I was talking about that are limiting the treatment in the children. So for the exploration, of course, functional MRI is very, very limited in children. For surgery, particularly in infants, the two main of concerns is the reduced volume of blood and, of course, the poor thermoregulation. We will talk after about also the mapping, but what about also the adjuvant therapy with the toxicity of chemotherapy, radiotherapy? And we know that some target therapy that are used in some trials have a lot of side effects in children. So surgery, as I said, for the both for the low-grade gliomas or the high-grade gliomas is the cornerstone in most locations, except of course the optic pathway and the DIPG. We will talk about that after. The goal, of course, of surgery is the gross total resection, because as I said, the extension of resection is a strong prognosis factors. But sometimes we have to consider the quality of life, particularly considering the environment of the patients, and maybe we have to consider subtotal resection, but it will imply that we will have a less PFS, a less overall survival at 5 years. So for surgery, of course, we have to take in consideration anesthesia. When we are dealing with children, we have to have beside us a very well-trained team, particularly for infants and young children. And you can see that the main concern is with the CBF. And you can see that in children, it is more important than adults, and it can consume as much as 1/4 of cardiac output. So this is a very important consideration to talk about. And also we used the inhaled anesthetics, but we commonly in this surgery, but we know also that they are strong vasodilatators, so it can be challenging during anesthesia. The blood loss, I talk about that, and sometimes in some departments, we have to deal with surgery in 2 times. I know that adult surgeons who are dealing with meningioma and skull-based pathology said the first time is the best time, as said Professor El-Mefti, but I think in young babies in poor conditions, we can use the surgery in 2 times. And it is our policy when we are dealing with children younger than 1 year generally. This is an example of a patient that we have treated. You can see 2 years with a macrocrania with this huge tumor, and we have operated in 2 times. It was fortunately a pilocytic astrocytoma, and the surgery was done in 2 times. For the tools, Professor Tanju Utsal have talked longly about ultrasounds. It is cheap, it is a good investment for a hospital, for a department, and it is also an imaging in real time. Of course, navigation, most of the department have navigation now, but sometimes the problem is that we can't integrate DTI because DTI is not available in the preoperative imaging. Of course, we can add some things like this minimal invasive tubular retraction system for deep-seated lesions in combination with navigation, and it can make easier to accede to the deep-seated lesions. What about intraoperative monitoring? I mean, about the supratentorial lesions. This very beautiful paper published last year by the team of Shlomi Constantini showed that the EON has a role even in infants. It may facilitate the maximal safe resection, but it must be tailored to patient age. Of course, we know that with the other studies that there is certainly an advantage of monopolar short train stimulation over the pen field stimulation. And of course, we can't not use all the full EON techniques that are used in adults. So we need, of course, a large prospective cohort to implement the DTI, the navigation, and also we must have a thorough early and late neurological evaluation to see really the valuability of this EON. Awake surgery, people are talking about awake surgery, of course. In adult, it's nowadays it's routinely done, but in children, it is still under debate, and people use it reluctantly because first of all, there is a lower incidence of eloquent lesions in children, and people are always afraid about the psychological fragility of children. But I must say that sometimes you have some children that have psychological personality more stronger than adults. But good results have been reported in different series. And the most debatable aspect is the age limit. Of course, we will not talk about that in children before school aging, but maybe after school aging, we can talk about that. We can make psychological preparation, and also we know that age is not equal for all the patients. And sometimes in terms of maturity and comprehensive capacities, and sometimes we don't have, we must not forget that maturity can be, and comprehensive capacities can be challenging by the disease itself. And sometimes maybe we can also do additional supportive methods such as hypnosis. I must say that in our department, we use hypnosis for many things in children, such lumbar puncture or things like this. And but we are not dealing now with awake surgery, and maybe when we will do that, maybe we can have hypnosis as adjunct function. What about magnetic resonance guided stereotactic laser? Recently, this paper has been published. It is a retrospective study of multiple institutions of 86 cases. I must say that it is not broadly used, but what is important to know is that we can have risk of generated thermal lesions. And of course, it is a very important investment. And of course, we have to see the results at long time, because we know in this series that there are some children that have secondary surgeries, mainly in high-grade gliomas. What about intraoperative imaging? I think that Professor Tanju Utsar has talked about that. With the MRI. We don't have all MRI in our departments. In Algeria, for example, we don't have perioperative MRI. And furthermore, when you make an investment in high field machines, you have to have adequate surgical instrumentation. So I just want to say some words about the IPG, this frustrating tumor that we are dealing with, and which is very frequent in the brainstem in children. And you can see that the main problem with this tumor is the resistance to chemotherapy and target therapy, because the relatively intact blood-brain barrier. Which is traduced by the poor enhancement of this tumor. And as I said, Professor Fella Terkmani, this DIPG have in nearly 80% of cases the H3K27M mutation. And so these gliomas are definitely a grade 4, very aggressive gliomas. And there are also other molecular aberrations that may be represented in the future targetable subgroups. So the stereotactic biopsy, I think, will be the standard of care because these nice papers have shown that the risk is very, very low. The mortality is near the 0, and it can give a lot for the future trials and for the treatment. What can we expect in the future in surgery of the IPG? First of all, the disruption of a blood-brain barrier, maybe with the low intensity pulsed ultrasound, the CED and osmotic pump delivery. Maybe we can in the future deliver inside the tumor some nanoparticles or some other agents with target therapy and so on. And just to show you some frustrating case, this was a young child of 30 years who came with a headache. And you can see this imaging with this very infiltrative tumor. We have done a biopsy. After that, the patients have an aggravation. We have to do an emergency and decompressive craniotomy. He had a STUB protocol, but you can see the progression after the STUB protocol, and he died nearly 1 year after the treatment. Another case of a young baby of 3 years. She was treated in another department, for this lesion. And it was at this time, we sent, the pathology was done by our friend Fella and confirmed by Figarella in Marseille, and said maybe it's an aggressive xanthoastrocytoma. But she was in another department, she underwent chemotherapy, and of course chemotherapy didn't work in this patient. And we have operated on June 2011, and it was a subtotal resection, and everything was okay. And you have the imaging at 6 years after follow-up. And unfortunately, she returned 10 years after with this huge recurrence, and at the operation, it was a transformation in epithelioid glioblastoma, which is a rare thing since we know that malignant transformation in low-grade glioma in children is near 5%. And unfortunately, she died in spite of the treatment. And this is another case to show when you don't have DTI, when you don't have tools to deal with these thalamic tumors, This was a girl of 30 years with intracranial hypertension, with hemiparesis, and we just done a partial resection. It was a pilocytic astrocytoma. So we discussed with our group and we give her chemotherapy, which was an LGG4 shim. And fortunately, you can see the shrinkage of the tumor. And so now she finished her chemotherapy and there is no recurrence till now. So in conclusion, gliomas in children are frequent lesions. They are heterogeneous. They are unfortunately age-limited factors for treatment. The surgery is the cornerstone of the treatment till now. Of course, surgical tools have improved the extension of resection. We have a great hope with intraoperative neuromonitoring, but unfortunately, high-grade glioma have still a very poor prognosis, particularly the DIPG. For LGG, chemotherapy can help, and maybe also the inhibitors of BRAF, and of course, the main concern that we have with these young children is the quality of life. Thank you for your attention. So, yes?
They have just a comment. It's possible,
yes, okay,
or you are.
You will begin the discussion.
Thank you, dear Suad. Really, it's an amazing webinar because it's, as you said, as you told, it's you know, future science fiction first, and then we move to the reality with your talk in the end. But I would like to congratulate the Algerian Society for this really outstanding webinar, and all the speakers, especially our guest from New York, Isabelle. She was really very, she gave a superb, amazing talk. And Tanjur, also, sorry for the spelling your name, but you know, this intelligence, the iPhone is sometimes not really about, you know. So I have maybe, and our colleague for, of course, neuropathology, she was really amazing also, and all you told him. You named him the Mr. Awake Surgery in Algeria, Mr. Abdelrahman. Congratulations. So I'm really, it's very, very interesting to know that you have a big experience, more than 100. It's very amazing. And you show us a very, very nice talk. So I have some, maybe two questions. One for, do you think that I put it in my comment in the sharing with everybody in this webinar. Can in your thought, it's possible to have some, of course, robot or something like this, replace the neurosurgeon in less than 1 century? Because we know, all of us knows that we know less than 30 or 40% of connection in brain connection, physiologically speaking. So I think it's I would like to have your answer about this comment. And I have also a question for our colleague Abdelrahman about awake surgery. In your study, you have some children, and I know I just operated on Monday my first cases children. I have 20 or 25 cases till now, but the first children I operated him on Monday, and I was very surprised when operatively he told us, you know, my legs is I can move my legs better than when we start the surgery. And of course, I told him it's not objective, it's subjective feeling. But in the day after, when I did the exam, effectively he of course comment on dit, he récupéré, Suad, help.
Recuperate, improved.
Yeah,
improved.
Yeah, increase his motor deficit, and I was really I was really disappointed, and not disappointed. I was really it's amazing, but I don't understand what happened, because it's a glioma, it's a temporal glioma. And I don't understand what happened. This is why I am telling that we don't know. I think less than 40% of the all the connections, the brain connections, and the connectome, as we said. Thank you.
So the first question was for Professor Tanju?
And Isabel.
And Isabel, okay. And the second was for Abdurrahman, okay.
Yeah.
So.
Let me tell me my very honest opinion about robotic surgeries. The first is for doing a good brain surgery, for doing a good neurosurgery, we need a good anatomical knowledge. First is good anatomical knowledge. The second is, of course, the surgeon skills. Without that, if you use virtual surgery, if you use robotic surgery, or if you use whatever you want, you cannot succeed. That is why robotic surgery is, for my side, is looking a little bit far for our general practice. I don't know what will happen in the future, but if you ask me my honest opinion, now I am not believing that.
Yes,
I believe my hands.
Yeah, I totally agree with you. Okay, thank you.
So I agree with what has been said. I think that there are niches in our profession where automatization will take over. And a good example is pedicle screws. So I think that making the decision of whether or not a patient needs surgery, it will still take our input, although there are more and more outcome predictors based on artificial intelligence that can be used. But ultimately, to really place those pedicle screws, I could envision some of the machines that we're using now that are faster and more precise than us. With that said, we, not just we neurosurgeons, but we pathologists and neurologists and other medical doctors are still going to be needed, because we need to control those robots, right? So the reason why the robots now are able to do is because we were able to go up to a certain point. And I think that we're still needed to do that. And so is the neuropathologist, will the neuropathologist be replaced by the computer? And my answer is no. Sure. But her skills or his skills are going to be enhanced by the computer. And so I think that for the next 100 years, I will see the same with myself. Will I, well, I don't think that I will survive 100 years, but will the neurosurgeon be replaced by the machine? And the answer is no, but she or he will be a better surgeon because of the machine. And that after all that said, we don't have a crystal ball. So for instance, look at what happened with COVID. Nobody was able to predict that this happened. And so it did happen. So we need to keep an open mind, and we can never exclude a possibility, but we have to work with what we have.
Yeah, so that's right. Absolutely right.
So I think now it's Abdurrahman. Micro, please.
Yes.
Voilà. We hear you now.
Thank you, Professor Abedi, for your interesting question. Sorry, I haven't experienced in children operated by awake protocol. My youngest patient have 18. The reason is the child don't cooperate with us, but some other use children hypnose and good technique. They have the good results. Thank you.
The last one that I told you about it is 13 years, and really it's the one of the best case that I operate with awake surgery. I think it's by pure chance, but in the future I will maybe I will make more children and I can give. But in the literature, there is with Jifu, with in Rabat, we are a department who have had more than now 50 patients, and they have more than 20 cases of children, and it works very well, more than adults. They told that, I'm not sure, but my first cases was really very good, and I think it's by pure chance. Thank you.
I just have to make a comment, Najia. I think that, as I said, the problem is not in the age, and maybe these children before surgery should have a psychological evaluation to see if they will cooperate or not, because we have seen many things in children. And it's so amazing that I think that maybe Abdurrahman in the future we will do that, and maybe he will have a psychologist, pediatric psychologist that can test the children before surgery. I think that you can do that, and maybe you can have children that will cooperate.
Of course, we did always the psychological, of course, statement, and of course, to preparation for this child. We took time more than usually with the adults. With the adults, our orthophonist prepared them for 3, 4, 5 days. But for this child, he took time. He took, I think, 2 weeks before operating him. It is very important. You are right. So thank you for this.
I think that we have, I have one question that have been on the chat, but by Professor Sahli. He's asking Fila about, is there anatomopathological element to predict a better radiotherapy prognosis? First, and how about the sensitivity of target therapy with also the element of neuropathology?
So thank you. I don't see the question, but
but it is on my chat. Me.
Thank you. No problem. Thank you very much for this question. For radiotherapy, we have different kind of tumors. So I think in the future we have to change our kind of therapy, and we see that with glioblastoma, and perhaps in the future we can find other target therapy, for example, for BRAF, TRT, MAP kinase. I think in the future we have to change the therapy for children. I think it's more important for children because radiotherapy is not the first kind of treatment for our children, and in the future, I think neuropathologists can give more and more with the molecular profile. And now I think this question is for my friend Gashi for the chemotherapy, and for us neuropathologists is to give you more and more information about the tumors. I think it's the best thing we can do for neurosurgeon and for clinician.
Thank you.
Yes.
Is it okay?
Okay.
Isabel, there is also a question about awake surgery in Mount Sinai in children.
Okay, so I would like just to latch on the targeted therapy and the fact that the molecular signature is very important. At the present time, we don't have any molecular signature that can guide radiation therapy, but clearly for high-grade gliomas, and particularly for GBM, we prefer to go with the stoop regimen. And then when and if the stoop regimen fails is when those other molecular markers are very important, because then we can use a more focused approach depending on which are present. So awake surgery for brain tumors at Sinai, not performed. I think just like Naja has said, my youngest patient was a 12-year-old. She was a fully developed child. She was as big as me. And psychologically, she was incredibly well set. She worked with the neuropsychologist and so on and so on and so on and so forth. But I agree with you, Swad, that in the future, it is a good idea for the neuropsychologist to work with the children and hopefully by so doing, preparing them. And there might be some that can really withstand the operation with an awake procedure.
Okay. Professor Bouyousef, do you have a comment? Micro.
It was a very, very nice webinar. I have nothing to add. You are the specialist of the question. But thank you very much for this very nice organization. Thank you, Isabel. Thank you. Najia, how are you doing? You are in
Fine,
Francisco.
Mr. Ando.
No?
Oh, yes, yes. You say the picture behind me. So thank you, Mr. Endoscopist.
Thank you. We have also Professor Abdenbi. Maybe he wants to add a comment. Professor Abdenbi? No, I think there has a problem of connection. I just want to ask.
Good evening. Good evening.
Good evening.
Very nice webinar. And we thank all the participants. And see you in another occasion, inshallah.
Thank you. I just want to ask the speakers about experience in intraoperative neuromonitoring in children. Do you have, what do you think about the stimulation, and is everything possible? I don't think that everything is possible in children because it's totally different than adults. And what can we do really as maybe standard intraoperative neuromonitoring in these glial lesions? Isabel, if you want, or I don't know, you can answer, can give us your opinion.
Yeah, so I don't do pediatric surgery anymore. It's been a long time since I have. And I think that it is age related when the cortex is basically just, I love the first slide that you have of your talk, that a child is not a small adult, right?
Yeah.
A child is different, but there will be a point where that child becomes a small adult. So I believe that around 14 or so, that you can use the same cortical stimulation SSEP. But before that, it's really totally different. So I'm interested in your opinion and the opinion of the other panelists about the possibility of standardizing the intraoperative monitoring for that.
I totally agree with you, because when we talk about children, and as I said in my slides, the problem is with the infants and young children. This is the big problem. Of course, when we have children over, we will say 12 years, they are adolescent, and as you said, they are young adults, maybe. of course, biology is not the same, but we are close to the adults. But of course, when we are under 10 years, things are totally different. And I don't know if
What happened?
in the immediate future we will have. I think he has a problem of connection.
Yeah.
We can't hear you.
We don't hear you very well.
حافظ جمل هنا faites-lui dire
Yes.
le mot.
Oui, oui, bien sûr.
Just to maybe give a small comment about this intraoperative monitoring. It's two types, different types. Of course, we are talking this night about the awake surgery. Awake surgery less than, I think, 7 or 8 years is not possible. Not possible. It's really illusion. But of course, we use intraoperative monitoring for a small for children less than 8 years. For example, for spinal cord tumors, for example, for brainstem tumors. We use it, and it's different because you collect the answers, the stimulation by electrophysiologically. That's not by motor deficit, or it's two things different from awake surgery to intraoperative monitoring for some lesions, spinal cord or brainstem or others.
So I did find a slide of my pediatric talks, and what Naja was saying is exactly the point. So this slide here shows that if the child is less than 5, the cortex is not excitable, and therefore you cannot use the direct cortical stimulation. However, you can use SSCPs, and SSCPs are helpful for mapping. This is a picture of an adult patient that I'm monitoring, and here is how it works, right? So the somatosensory evoked potentials, they do a stimulation of a peripheral nerve. Usually we use the median nerve, and then they do a computer average short latency evoked recording from the sensory cortex. And then the latencies are used, and you're really looking at these differences in the NP wave, and that is your phase reversal right here, the phase reversal. And this is what is allowing you to decide motor versus sensory. So you cannot do direct cortical stimulation, but you can use SSCP to identify motor and sensory cortex.
Right. Yeah, right.
Totally agree.
Totally agree. Yeah.
Okay. I think that we have Professor Jmel with us. Professor Jmel from Tunisia. I think he has a problem of connection. No?
Oh, hi.
Professor Jmel, do you hear us?
Oui, je vous écoute.
Thank you. Do you have comments?
No comment.
No comment.
No, it was very good webinar.
Thank you for attending. Thank you for attending. Do you have, Nabila, do you have other questions from the floor?
No, there is no other questions.
Yeah.
Yeah. If I can, just a precision for Isabel. In intraoperative, we don't use frozen. I agree with her because we have some artifact, but for us, and you know that because we work with you, we use a smear. A smear is just to see cells, and it's very, very without any artifact. So just for this position.
Yeah, it is actually, the smear is more, it's easier to use and there is less false results. But as you well know, because you are a pathologist, the smear can only give you so much information. So you're losing really the entire picture of the tumor, because you only know if a cell is present or absent. But I totally agree with you that the smear intraoperatively, it's easier to use and more reliable. I think that what I was showing before with the intraoperative spectroscopy and the possibility of doing that analysis is something that will allow us to basically use the cell morphology, but also to look at the entire cytoarchitecture of the tissue, which is really what you as a pathologist like, because you need to have both. But definitely the smear is the best way to go.
I think that Sahli would like to ask a question. Is it right or not? I see you handing your hand. So do you want another question or?
Thank you, Professor Bakhti. Thank you for those amazing presentation. We was honored by our guests. And just a request, and for you, Professor Bakhti, because it's an activity of the Algerian Society of Neurosurgery, is it possible to extend the participation of the activity of the Algiers group of pediatric neurosurgery via Zoom or other application to all of us? We tried this with the National Committee of Pituitary Surgery, and it was great. I think that you can help us to learn so much. Thank you again, and thank you for Thierry.
We will look at this possibility with Zoom, but you know that we are dealing with all the pediatric tumors of Algeria in this group. You know that. So just we have to organize a Zoom. Yes, we will definitely do that. Thank you. I just have to ask one question about the exploration, standard exploration for gliomas. Of course, everybody knows the utility of all the sequences, but we have also to think when we are in limited resources. And many people in this webinar are from countries such as Tanzania, such as many countries, India, what are basically the sequences that we need? The standard requirement in imaging, for example.
You mean the preoperative images?
Yes, preoperative imaging, yes. Yeah.
May I have a comment, Suad, about this? Because of course, we need all the sequence, and especially for the glioma, we need functional MRI. It's very important. I think your colleague Abdelrahman told about that, but it's very important for the imaging, the preoperative imaging, before to decide, of course, awake surgery or other type of surgery.
But
and DTI, of course, if you can, you know, my collaborator, Dr. Fahd Al-Qawi, he did really a nice, beautiful works about DTI, combination to DTI to the radiosurgery for the glioma, all type, benign and malignant, and combining the DTI to the you know, all the imaging, and I think my dear Isabel, you are we will agree with us, because it's till now there are no published paper about this combination of the DTI to the radiosurgery, and he did this work, and he had his PhD about according to this work. I will share with you this work as soon as possible.
Yeah, I mean, we know that, but what I'm asking, because we are in a course and we have different levels. And of course, we know also that some people who are using awake surgery said to you, okay, I will do a functional MRI because there are medical legal issues. But they said to you, I didn't need it. And you know, I'm talking about Hugues Dufaux, for example. And I'm asking for LMEC, what are the standard requirements? Because of course, when you are in a super hospital, you have all these tools, so everything is possible. But what are the standard requirements?
But functional MRI for me is a standard requirement for awake surgery, for example. It's not lux, it's a really basic exam to have before to start to operate a patient with awake surgery. It's my opinion. I don't know what Isabel think about that, but really it's standard. This is the basic you know, sequences or exam before she will.
Yeah, so I think that I am I have a lower standard than that. I understand SWOT question, and the question is, in the presence of very limited resources, what can I do that is safe for my patient? And I go back to this paper of Mitch Berger in 1990, showing that really a T1 weighted or a T2 weighted image, it should be sufficient to locate the central sulcus and therefore to have a very good understanding of the preoperative anatomy, motor versus sensory. Now, for speech is different. So for speech, that functional MRI brings in additional information. But again, for all those other cases where we're trying to understand motor and or sensory, looking at the central sulcus and the side preoperatively. So in these two cases, as you can see, the awake procedure or the mapping procedure was done. But one could make the case that for the tumor that is way ahead of the central sulcus, there is really no need to use all those resources, and that you could do this surgery on this particular side, on the left side of the screen without that. Whereas the pictures on the right show the infiltrative tumor that is invading the motor cortex, and there is where you need to use more resources. So to answer SWOT question, I think that we cannot standardize the answer too much, but we need to understand what is the question that we're trying to ask? What is the patient population that we want to address? And so each tumor and location within the brain might have a different answer in the presence of limited resources.
Thank you. No. Abdurrahman. Abdurrahman, could you give us your opinion, please?
Yes, I can. If you have a good experience of stimulation in awake, functional MRI and DTI is not indispensable, but you must practice a lot of catabolic dissection. It's a question of experience.
Okay.
Thank you.
Thank you. Is there any comment? So thank you. I think that I think there are not other comments. Professor Tanju? No? Okay. So thank you so much. Thank you so much for all the attendees. Thank you so much for all the speakers. And I hope that our young neurosurgeons and the less young have learned. I'm sure that they have learned, because I've learned today, and each of us have learned. And thank you so much, Isabel, to accept to organize this webinar of Education and Training Committee of WFNS in collaboration with the Algerian Society. We hope that we will have more collaboration in the future. And again, thank you. I will say also thank you to Nabila for the organization. She is always here, and hope to see you next webinar. Our next webinar is on the 27th July with Anil Nanda. We will talk about skull-based surgery. Voilà.
Thank you. And
thank you so much for being here. Thank you so much.
To the next time. Bye-bye.
Congratulations, Suad. Congratulations. Congratulations to all the Algerian society.
Thank you very much.
Bye-bye.
Bye-bye. Bye-bye.
Bye.